All right. Welcome back to another episode of Clinical Appraisal. I'm your host, Ian Lane, and today I'm going to record both the podcast episode and also a YouTube webinar. So if you're on the YouTube channel, Clinical Appraisal, you will see the slides for these data at the same time as I am speaking to you. Today's episode will cover the potential role of vitamin D and vitamin D status in COVID-19. First, a disclaimer. Everything to follow this is for educational purposes only. I'm a clinical research scientist. I am not a licensed physician yet, and none of this is medical advice. So starting us off, there are some interesting new data from molecular docking studies to show that calcitriol could potentially bind to the receptor binding domain on the spike glycoprotein of the novel coronavirus, SARS-2, which causes COVID-19. It's important to realize that molecular docking studies are done in silico with bioinformatics techniques, which are very important and very reliable, but on the grand scheme of things, they do not reflect even in vitro or in vivo research. These are all sort of hypothetical computational models that show that certain compounds can be expected to reliably bind to the RBD. And while this is very important, it hasn't been demonstrated clinically or in animals or even in a petri dish yet. Now, it is important to realize that these studies are, as I say, pretty reliable. These typically, though, tend to be used to determine what may end up being good drug targets later on. However, it is important to know that calcitriol, which is the active form of vitamin D, or 25-hydroxy-D in the blood, that calcitriol can bind to the RBD of the spike glycoprotein. So that's one way in which vitamin D could potentially start us out in being important in COVID-19. We've known for a long time that vitamin D status affects lung disease and that it has an important role in lung health. For example, we know that the vitamin D binding protein has specific immunomodulatory functions relevant to the lung, and that macrophage activation and neutrophil chemotaxis occur in the lung specifically with vitamin D. We also know that respiratory epithelial cells tend to convert inactive vitamin D to its active form through 1-alpha hydroxylase activity, and the 24-hydroxylase enzyme, which reduces or inactivates vitamin D, tends to be lower in the respiratory tract specifically. So respiratory epithelial cells tend to have higher levels of 1-alpha hydroxylase, which to me indicates that vitamin D has a very important role to play in respiratory epithelial health and host defenses. Similarly, sinonasal epithelial cells will actually synthesize an active form of vitamin D, which will augment the innate immune system function. And these sinonasal epithelial cells generate a significant increase in something called cathelicidin antimicrobial peptide 18, or CAMP, C-A-M-P, which has direct antimicrobial and antiviral activities within the cells. We know that vitamin D is very important for asthma, and being an inflammatory condition of the airways, asthmatic lung tissue tends to be pretty correlated, strongly correlated with vitamin D status, in the sense that the lower the vitamin D, the higher the inflammatory responses and the pro-inflammatory cytokines in the asthmatic lung. We also have data to indicate that school-aged children with severe asthma exacerbations tend to do much better when their vitamin D status is sufficient, compared to vitamin D insufficiency, where they tend to have higher plasma cytokines and do much worse. Vitamin D is also implicated in chronic obstructive pulmonary disease like emphysema. And we know that emphysema and COPD are significant risk factors for more severe disease in COVID-19. In fact, having COPD will predispose you to an 8-fold higher risk of critical illness of death from COVID-19, actually, if you heard my last podcast episode or webinar. And vitamin D is very important in reducing COPD exacerbations and improving lung function in these individuals. Vitamin D status is also associated with less severe community-acquired pneumonia and more, there's a higher rate of death at 90 days from community-acquired pneumonia in the hospital for those who have lower vitamin D status. Now, most people, when they think of vitamin D, they think of the skeletal system. They think of bone health. And while vitamin D and calcium, for example, metabolically are very important in bone health and bone metabolism, there are extraskeletal implications for vitamin D that have not been explored to their fullest extent until recent decades, where now we know that vitamin D regulates over 2,000 different human genes, and that's just what we know now. And we're learning consistently, year after year, more about the very important role of vitamin D throughout the body and across body systems. And this classic 2006 paper by Dr. Michael F. Hollick from Boston University called High Prevalence of Vitamin D Inadequacy and Implications for Health, which is a review paper, which is a fabulous paper, goes across many different studies that he and Dr. Martineau and others have conducted over the decades past, and explains epidemiologically, explains the pathophysiology and the human biology of vitamin D status and its relationship both to health and disease. And it's worth the read. I would recommend it. We know from Dr. Hollick and his other colleagues that vitamin D deficiency has become a worldwide problem, and that its health consequences are wide-ranging and are definitely not relegated specifically to bone health. And we also know that it's not just vitamin D deficiency, frank deficiency, it's also vitamin D insufficiency. And having a slightly lower than optimal level of vitamin D is actually a predictor of poorer health outcomes as well. We know from NHANES data and other large observational epidemiology studies that something like 40% of US adults are insufficient or frank deficient in vitamin D status. I think 42% in the NHANES data showed frank vitamin D deficiency. And we know that individuals with darker skin tones, for example, individuals who have higher melanin levels in their skin, so Black Americans or Hispanic Americans, they tend to have lower and slower conversions of vitamin D from the 7-dehydrocholesterol in the skin into the active form of vitamin D, and thus tend to have lower vitamin D levels in comparison to white Americans or white people in general. And they also tend to be the ones who are hit harder in a statistically significant way thus far, it seems, from the COVID-19 disease. So speaking of that, let's talk a little bit to the vulnerable populations, both for vitamin D status and for COVID-19. Now, keep in mind, these are just correlations, but it's important to point out. As I mentioned in my previous episode, Dr. Brayman from the chemistry department at Syracuse had posted this very interesting graph demonstrating that in his preprint, vitamin D deficiency correlates with a higher latitude, obviously. However, it also correlates with higher risk of more severe and critical disease and death from COVID-19. And It is not sufficient to be closer to the equator and have a lower latitude for you to not be predisposed to vitamin D insufficiency or deficiency, because we know that people from southern Arizona and people from South Florida are also at risk. And it could be, at least in part, a function of people not spending that much time outdoors or being physically active. And obviously, our rates of obesity tend to show that people tend to sit around at their desks and play with their computers more than go outside. We also know that individuals who are more aged, older adults, tend to be very low in vitamin D. There's some evidence by McLaughlin and Hollick to show, and this was all the way back in 1985 in the Journal of Clinical Investigation, that as you get older, your skin's capacity to convert 7-dehydrocholesterol in the skin to 25-OHD actually goes down substantially. So you make less as you get older, and they tend to be the ones with the most severe risk for critical illness and death from COVID-19. We also know that African Americans have a lower level of vitamin D, a slower conversion as well of vitamin D, given the high melanin level in their skin. But we know that from the study from Garrett Meyer et al. In 2012, that supplementation with vitamin D3, which is cholecalciferol, for 4,000 IU per day for a year, it completely eliminated the difference between white Americans and African Americans' blood levels of 25-OHD. And so supplementation could be one way to surmount this problem. We know as well that sleep problems are consistently underdiagnosed and undertreated and very prevalent in the United States among people of a variety of age ranges. And sleep apnea has a significant impact on vitamin D. In fact, CPAP treatment, or continuous positive airway pressure treatment, in obese subjects with, and this was just males, but obese subjects with OSA, or obstructive sleep apnea, had an independent improvement in vitamin D status. We also know from systematic reviews and meta-analyses that vitamin D and obstructive sleep apnea are inversely related, but it could also be due to body mass index. We know that in obesity, there's a decreased bioavailability of vitamin D and lower vitamin D more generally, which is associated with worse outcomes. Now, let's talk a little bit about vitamin D and human immune system function. We've known for some time that vitamin D status plays an important role in human immunity. We're going to talk a little bit about some of the research studies on acute respiratory infections and different virus infections from the perspective or the vantage point of having lower vitamin D status or conversely supplementing with vitamin D. But there is some preliminary evidence even to suggest that its role in human immunity is so important that if you have low vitamin D status, you actually have a lower response to vaccination. Now, this, I think, it is quite preliminary, but I think that there's some interesting data, and we need some follow-up on this, because if 40% of U.S. adults are insufficient or frankly deficient in vitamin D, if we believe the NHANES data, and also individuals tend to not vaccinate on a pretty large scales, even in the ones that do, if there's a lower response to vaccination, our herd immunity to things even like the seasonal flu may be compromised to some degree. We know that vitamin D across studies has some role in the prevention and treatment of infection, which you can see if you look at the meta-analyses of clinical studies, which I'll show you in a few moments. And vitamin D actually increases the antiviral activity specifically in the respiratory tract. I mentioned earlier how there's a higher level of 1-alpha hydroxylase in the respiratory epithelium, but there's also a specifically antiviral activity in the bronchial epithelial cells specific to vitamin D status. Now, this paper was in an in vitro study, but they were human epithelial cells, and this was a quite convincing paper, which is, again, worth a read. Now, vitamin D may produce its antiviral capacity through the production of defensins, which are proteins which have antimicrobial properties inside the body, as well as something called cathelicidin antimicrobial peptide, or CAMP, C-A-M-P. And we know that vitamin D is a powerful inducer of cathelicidin proteins. We know that the active form of vitamin D, calcitriol, or 25-OHD, stimulates the gene expression of cathelicidin, which is important not just for infection, but also for the destruction of things like cancer cells. And the antiviral activity of human cathelicidin has been demonstrated not only in pandemic or epidemic influenza, but also in things like RSV in young kids. RSV is a lower respiratory tract infection in individuals like infants or the elderly or AIDS patients who are immunocompromised, cancer patients, and human cathelicidin proteins are very important in fighting against these infections. We also know that low plasma levels of cathelicidin antimicrobial peptide, or CAMP, tends to predict disease and mortality from infections in various subpopulations. In fact, cathelicidin antimicrobial peptides' relationship with vitamin D in the critically ill has been examined and showed in this one paper by Leaf et al. That having lower vitamin D status in the ICU is associated with a greater risk of 90-day mortality. And people with lower vitamin D status had worse outcomes in the critical care setting. So briefly, just looking at some observational data, the NHANES data showed that, quote, serum 25-OHD levels are inversely associated with a recent upper respiratory tract infection. This association may be stronger in those with respiratory tract diseases. Randomized controlled trials are warranted to explore the effects of vitamin D supplementation on respiratory tract infection, end quote. This was in 2009, which looked at just under 20,000 subjects. And of course, there have been many randomized clinical trials since then. So looking at meta-analyses of the randomized controlled trials, there are 3 different randomized controlled trial meta-analyses that have been done by various research groups that all show that vitamin D supplementation has an important role in thousands upon thousands of people. But the most important paper published in this arena was by Martineau et al. In 2016, which was published in the British Medical Journal, and it was a systematic review and meta-analysis of individual-level participant data in over 11,000 subjects, ranging in age from 0 to 95 years. And they showed, quote, vitamin D supplementation was safe and it protected against acute respiratory tract infection overall. Patients who were very vitamin D deficient and those not receiving bolus doses experienced the most benefit, end quote. If you look at these data, the actual data, you see that the people who were the lowest in vitamin D were the most protected and the most impacted in a positive direction by vitamin D supplementation. Now, a very important, and before I move on to ACE2 actually, which is what our next slide says here, one of the lines I just read to you was a very important one, because if you look through the randomized controlled trial data, the individual studies, there tends to be some discordance among some of them, where some claim that there's no benefit and some claim that there's benefit. It turns out that there's less benefit if you look at large bolus doses of vitamin D. So sometimes your clinician might prescribe 50,000 IU at the beginning of the week, and then you go, 5 days, 6 days, 7 days without any vitamin D supplementation. But the research studies that supplemented with 1,000 or 2,000 IU a day for 7 days, they tended to have much better results. And so there's something about the pharmacodynamics and pharmacokinetics of supplementing with vitamin D on a more regular basis, on a daily basis, which produces more satisfactory outcomes. So moving on to angiotensin converting enzyme 2. Now, I mentioned previously, and it's important to note that the angiotensin converting enzyme 2 receptor, ACE2 receptor, is how the SARS-CoV-2 virus enters the cell and transmits its RNA into the cell to reproduce or replicate. Now, ACE2 is important for that purpose, but it's also important to note that SARS-2 or SARS-1 as well, we've known this for decades, for the last couple decades, that SARS-CoV viruses significantly reduce circulating ACE2. And there is a crucial role for ACE2 in preventing lung injury. Now, biology is never quite as simple, and this is a hat tip to Dr. Rhonda Patrick at this point over at Found My Fitness. Biology is never so simple as to, suggest that once you know one thing about a system, then you can make these larger, grand predictions about the rest of the system. Because while it is true that the ACE2 receptor is the site of entry, the portal of entry for the virus, as the virus replicates, it tends to cause a massive reduction in ACE2, and ACE2 is important in preventing lung injury and acute respiratory distress syndrome. The novel coronavirus, in particular, downregulates the ACE2, and that downregulation of ACE2 directly impacts the level of disease severity. We know that, of course, there's this problem of more ACE2 means, at least to some degree, an exponential increase in viral replication rates on the one hand, but on the other hand, the downregulation of ACE2 has a direct relationship with worsened outcomes in lung injury and acute respiratory distress. We also have this recent preprint paper by Montel et al. Showing that in human clinical grade soluble ACE2 injected into, well, in any case, they demonstrated that this soluble human ACE2 injected into mice had a very specific inhibitory effect on the SARS-CoV-2 infection rate. We also know that angiotensin converting enzyme 2, or ACE2, as I mentioned, protects us from severe acute lung failure and acute respiratory distress syndrome, which is how people who are mechanically ventilated and treated in an ICU for COVID-19 tend to expire. Acute respiratory distress syndrome itself leads to a reduced ratio of ACE to ACE2, and ACE2 specifically increases angiotensin 1-7, which is important for preventing lung injury. And this has to do with the renin-angiotensin system, or the RAS system. And as you can see on the screen here, vitamin D has a very particular regulatory role in this renin-angiotensin system, which is why vitamin D has some correlative relationship with blood pressure. Now, it turns out that vitamin D itself alleviates the lipopolysaccharide-induced, or LPS-induced, acute lung injury that is regulated by this renin-angiotensin system. And there's actual evidence that vitamin D has a specific role in critical illness. So we've known this for some time, and interestingly, although the preventive world has looked at this to some degree, the critical illness world has been looking at this for some time. There was a systematic review and meta-analysis of critically ill children and the relationship of vitamin D deficiency in those children in 2017, which showed that multiple organ dysfunction and mortality in the PICU setting reduced with children's vitamin D levels increasing over 50 nanomoles per liter. And there's also this paper published in the BMJ Open Respiratory Research Journal in 2015, which showed that vitamin D deficiency before hospitalization, prior to hospitalization, those levels were associated with the development of acute respiratory failure, and that vitamin D deficient patients who develop acute respiratory failure have worse mortality outcomes. And we also have this paper from Korean patients demonstrating that lower vitamin D levels were correlated with, inversely correlated with length of stay at the hospital and in the intensive care unit. So the lower your vitamin D levels, the more likely they were to stay in the hospital in the intensive care unit longer. And then there are data to indicate that vitamin D deficiency plays a direct contributory role to acute respiratory distress syndrome. And it is common in people who develop acute respiratory distress syndrome. So then the question must be, well, is there data on vitamin D in COVID-19, and or is there some reason to believe that it could be important for us in our examination of COVID-19? And it turns out that Grant et al. 2020, just this past March, published this paper in the journal Nutrients called Evidence that Vitamin D Supplementation Could Reduce the Risk of Influenza and COVID-19 Infections and Deaths. And they go over the public health research on vitamin D status and acute respiratory infection and other things, and they conclude that there should be a goal to raise blood levels of vitamin D of 25-hydroxy-D to between 40 and 60 nanograms per deciliter, which is about 100 to 150 nanomoles per liter. Also, on April 9th, Dr. Mark Olipio published in a preprint letter a paper called Vitamin D Supplementation Could Possibly Improve Clinical Outcomes of Patients Infected with COVID-19. And what he did is he split up patients into 4 groups: mild, ordinary, severe, or critical status. And then he looked at their blood levels of vitamin D. And I will just read you the conclusion. Quote, "For each standard deviation increase in serum 25-hydroxy-D, the odds of having a mild clinical outcome rather than a severe outcome were approximately 7.94 times. While interestingly, the odds of having a mild clinical outcome rather than a critical outcome were approximately more than 19.61 times. More generally, the odds of having a mild clinical outcome increase when serum 25-hydroxy-D levels increase. Alternatively, the odds of having a critical outcome increase when serum hydroxy levels decrease." Now, we won't know for sure if vitamin D treats or prevents COVID-19 in any meaningful way until the clinical trials come out. But as you can see on the screen, if you're watching the webinar, there are several different clinical trials in the pipeline. So we'll have to wait for the results of these here. And of course, it's not without its potential detriment. As I mentioned, there is this issue of vitamin D at high doses increasing the ACE2 receptor and possibly leading to an exponential growth of the viral replication process. However, all of these data coalesce together to indicate that there's some reason to think that vitamin D status could play a very important role in COVID-19. Thank you for listening, and I hope that you'll join me in the next episode of Clinical Appraisal.